Hi, thanks for joining me. My name is Ben Galen. I am a physical therapist. Been around here in Palm Beach County since 2003, both in the home health environment and outpatient environment. I'm the administrator owner of Evolution Rehab Group. If you need to get me, my phone number is 561-900-2423, extension 2. And I just wanted to take this time to just explain what is Part B, why do we do it, and that kind of stuff, so that maybe 5-6 minutes in you'll have a good idea. So really, what's going on with therapy? Well, with PDGM and PDPM, which was in the SNF, Medicare said, look, everything is weighted heavily on therapy. We don't get why we're paying so much for therapy. We should be paying for sick people, not necessarily therapy. They took the therapy case weight completely pretty much out of the nursing home under PDPM. That was in October. And then a couple months later in home health, PDGM, they took therapy out of being the main factor of the reimbursement as well, which is why you saw a lot of places lay off a lot of therapists in the SNF, and that home health all of a sudden cut back from doing these 20 visits a month to 5, 6, or 7 to try to avoid the LUPA. And what Medicare said is home health care, skilled home health care, is a bridge. It's not a destination. It is a bridge between a acute environment and home. It's not custodial care. It's not long-term care. And in fact, they frown upon things being done in ALF. Part of the coding on the OASIS for Medicare is this patient in an ALF, and it kind of downcodes it. If the patient's not coming from a facility, it downcodes it. If the patient's been seen for more than one 30-day period, it downcodes it. If they've been seen for more than one episode of 60 days, it downcodes it. And the reimbursement's getting such that they're rewarding acute, fresh patients. So a lot of agencies are like, well, I can't take this patient, doesn't make sense monetarily to take this patient who's got nothing much going on with them, but I don't want to upset the doctor, I don't want to upset the patient, so maybe I need to just push it to Part B in the home, which is outpatient therapy in the home. And bundles, like if you see nationally right now, all the total hips, total knees that are being done in bundles, most states are pushing those directly to Part B in the home. They're not even seeing them in home health. And that's what's shifting into this push into Part B in the home. There is pre-claims review that's coming into home health care, and the value payment option is coming into home health care, which will also push this. As I said, what's the difference? Part A, it's a bridge. Part B could be your final destination. Part A, you have to be homebound. Part B, there's no homebound criteria. Part A, it's paid for under the Part A benefit 100%, no copays or deductibles, as long as it's necessary, skilled, reasonable. Part B, 80% is covered by Medicare, and then their secondary supplemental, if they have one, covers the 20%. If not, each visit comes out to be roughly $20 for a patient if they have to pay cash. If they have Medicaid, Medicaid will pick up the secondary as well. Typically, with PDGM, most parts of the country, it's 4 to 10 total visits in those 30 to 60 days. For Part B in the home, we could go 3-4 times a week, and then taper down as we want to. For each discipline, speech and PT share a Medicare cap for a long reason from a long time ago. OT has its own Medicare cap. Sorry, I had a phone ring. Goals, again, on Part A, home health. It's about stabilizing a patient within their available and capable assistance. For example, if a patient has 24-hour caregiver assistance in Part A, and they're going to have that forever, then you can't really justify that you have to get them to independent in all ADLs, because they don't need to be independent. They need to be min or mod assist. On Part B, you can make them as independently and functional as possible within reason. You really should not refer to sports or athletics like patients have pain with golf. Medicare doesn't really like that. Pain with jogging, they don't really like that. But you can try to strive to get someone independent in all their ADLs on Medicare Part B. So when you see Medicare Part A, it should be a couple weeks getting them stable at home, and then flip them over to Part B for the intensive rehab. So on the left, it used to be hospital to either SNF or home health then discharge to outpatient, SNF to home health to outpatient. And that's how in Palm Beach County still happens a lot. We're usually behind the times. What it really should look like here is 3 options at discharge. Does the patient go to home health Part A to SNF or outpatient in home? Once they go to the SNF, do they go to outpatient at home? Once they do Part A home health, do they go to outpatient or in home? And same with Part A home health, they have the option of billing Part B in the home as well. Again, don't worry about Optum. We actually use different software now, but you really want to tell a story, why you're there, what you're doing, all the factors that are going to make it, difficult to get this patient better within 6 weeks. You want to set the tone early. that, yep, this person's got a lot of stuff going on, so it's probably going to be 12 weeks of treatment. What have they had for this condition response? You should be very objective in the areas of focus, meaning I don't need a range of motion of every body joint. I only need the range of motion of a joint that you're going to be working on because it's impacting their function. So if someone's shoulder is limited to 70 degrees and you think by getting it to 110 and that they can reach behind their back, well, then I need objective numbers. I need it to be 70. When you work on them, I need to see 90, 100, etc. So we really should talk about the patient participating and being empowered. Goals should be functional. The treatment should be functional. We should get at least, not at last, but at least one functional outcome measure. Everything should be unique to that patient. Part B, it's billed in minute blocks. The evals actually are just their own unit, and they're not in minutes. You do need to put that you were there for 10 minutes for an eval unit, but they're not part of this bundling of units. Medicare says anything from 8 to 22 minutes is 1 unit. So if you do like 8 minutes of Therax and 15 minutes of Theract, that's 23 minutes, it's 2 units. So 1 unit gets attributed to Theract, and 1 unit gets attributed to Therax. Where it gets weird, though, if you do like 22 minutes, let's say, of Therax, and 22 minutes, let's say, of Theract, which would be 44 minutes. If you go down the chart, that's 3 units. So one of those gets a 1-minute charge, and one of those gets a 2-minute charge. Usually the one that's more expensive gets a 2-minute charge is how Medicare likes you to allot it, which is therapeutic activities, number 1, neuromuscular re-ed and self-care, number 2, gait, I'd say number 3, Therax, number 4, and like the lowest paying thing is manual therapy by far. So you want to make sure you explain like what kind of activity you did for how long, and that sets up the minutes and the units. Again, with an eval not counting towards these minutes. Progress visits, research, discharges, etc. There is no eval codes. The only time you do another re-evaluation code is if you're like 4 weeks in treating a hip and now you've got a script for a neck and a shoulder, you do a focused re-eval with a new plan of care. You'd bill a re-eval unit, which in PT world is 97164. It's 97168 in OT world. And in speech, there's really just treatment codes that are untimed. So there's a swallow treatment code and a speech treatment code. Those are both untimed. So this goes through, you could pause this here. This goes through like how it all does, you know, if you did this many minutes and this many minutes, again, you could just pause the screen and look at it if you need to. Coding, you know, you need to come up with diagnosis codes. Things that are general, like just general muscle weakness. You can put that on there. Don't make it your first code. Your first code should be something else. Difficulty in ambulation is fine. If it's like a stroke, though, like hemiplegia affecting non-dominant side or post-residual effects of a stroke, that kind of stuff. Pain of left hip, pain of right hip is fine. But sprain strain codes are actually considered like accidents, which tries to say that it should be third party, like a car insurance, so try not to use that. If you're doing something that's left and right, please use left and right. Here's an example of medical and treatment diagnoses. Again, you can pause the screen here if you want to and look at it later.